This conference will now be recorded.
Excellent. Okay. Happy Friday, everyone. Welcome. I am so sorry that I was gone last Friday, but last Friday was really wonderful. I got the opportunity to attend the APIC National Planning Meeting. And APIC is heading in a really, really exciting direction. And so I'm definitely really glad that I was able to go experience that, participate. It was definitely a lot of fun. And I'm going to be the chapter president for the Central Florida chapter next year in 2023. So that's the reason why I'm attending. It's because they're already starting to plan all of 2023 and figuring out like the speakers and their deadlines and logos and all of this, all of this really fun stuff. So I hope that I get to see some of you in Indiana soon. If you're going to be in Indiana, let me know. If you're going to APIC, Indiana, let me know because I would love to be able to meet some of you soon. That would be just amazing. And then, oh, yay, Carrie's going, Zenith is going. Excellent, excellent. So I'm excited to meet some of you in Indiana and then again to see some of you in Orlando in 2023 because I hope a lot of you will be coming down for that. Okay, so our agenda for today is going to be chapter 10, general principles of epidemiology, surveillance, and then outbreak investigations, okay? All right, so some reminders. Believe you can and you're halfway there. All right, that's just the half of it. Believing you can pass this test, that you can prepare for it, that you can study for it is just the half of it, believing in yourself. You only get out what you put in. So this applies to everything in life, right? Your work, your relationships, and also this test. You only get out what you put in. I can tell you I've prepared for a lot of certification tests in my time as an infection preventionist and an epidemiologist working in public health. And it's not just about passing the test, okay? The information that you learn preparing for these exams will allow you to make a difference in the role that you're working in. So why did I pursue the vascular access board certification? Because I wanted to understand vascular access better. I needed to understand vascular access better to ensure that I had a much broader impact with the the health of my patients, our vascular access needs, being able to advocate for that team. It's just it's beyond the test. I know that a lot of you are focused on I need to pass this test, whether it's a requirement for your organization or for your hospital, etc. It goes beyond that. It is way, way, way beyond just passing this test because what you learn is going to help you keep your community, your hospital, the people that you love safer. Participation is important, whether you're participating in the live session or you're listening to me on YouTube. Just keep at it, okay? Whether it's this group or Patty's online group, or if you have a study buddy, however you're doing this, just continue participating, being involved. This is how you're going to pass. Keep your why in mind. Why are you pursuing this certification? Why is it important to you? It cannot just be about the letters after your name. There has to be a bigger reason why this is tied into your professional development plan. And like I said, it goes beyond the certification. The information that you learn will help you advocate, will help you grow your department, and just be a huge resource for your hospital, for your healthcare facility, for your county, for your state, for your country. Okay, there's some people at the federal level trying to, get certified. So let's go. We can all do it. Um, and it's all about just putting in the work. You put in the work and that's it. You get the results. Okay, so again, we already went over the chapters that we're going to be doing. Let me go back just one slide, if I may. So heads up, we are skipping week 6 and jumping into week 7. And there's a perfect reason for that. One of my besties, Danielle Rankin, you guys have heard me say her name over and over again. She's graduating with her PhD from Vanderbilt in epidemiology. So she is a epi baddie, like level 1005. All right. So she's actually going to be teaching us statistics after she finishes up her dissertation and her defense and her whole situation. I'm very excited and I'm very, very proud of her. And I think she's going to do a much better job of explaining the use of statistics and infection prevention than I can, because she understands the statistics much better than I do. And so I'm really excited for her to be able to do that. So the plan is for her to do a 3-part series, so 3 separate lectures on statistics, so that it really breaks all of those concepts down for you guys and that you get a much better understanding. Okay. All right, let's go ahead and get started. So chapter 10, General Principles of Epidemiology. So we're gonna start by talking about epi. Hopefully I have some MPHs in the group chat, some of our, some people who have their masters in public health or who have taken epidemiology classes, because it's a very, very great a field of study, right? We can say that as infection preventionists, we focus on our entire healthcare facilities. It's not just, patient to patient, we're focusing on an entire population. Okay, so what is epidemiology? So epi, with the Greek meaning on or upon, demos, meaning people, and logos, the study of. So in other words, the word epidemiology has its roots in the study of what befalls a population. And a lot of the times, we as infection preventionists associate epi with infectious diseases because we're working the majority of the time with infectious diseases. We're tracking our MRSA, we're tracking our VRE, our CRE, all of our MDROs. What do our admissions look like? Are we having a majority of respiratory illnesses? We're keeping an eye on a lot of infectious diseases. But it goes beyond that. When you really start diving deep into epidemiology, there is literally epi for anything that you can think of. So there's cancer epidemiology, cardiovascular disease epidemiology, like it's infectious diseases just so happens to be what we like, or at least what I like, but you can study lots of different things. So epidemiology, this is by the Centers for Disease Control and Prevention. Epidemiology is the study of the distribution and determinants of health-related states or events in specified populations and the application of this study to the control of health problems. Now, that is the CDC definition. What I will let you know is when you're taking the test, the definition that they're going to use and the definition that you need to know is the one that's coming from the APIC text, okay? The APIC text is the one that you need to make sure you have memorized. So epidemiology is the study of the frequency, distribution, cause, and control of disease in populations. It forms the basis of all health-related studies. It provides the background for interventions to reduce transmission of infecting organisms, reduce the number of healthcare-associated infections, and protect healthcare providers from infection. So this is the APIC definition. You have to make sure you know your APIC definition. Some of our key concepts. So, gotta love the Microsoft Teams. So some key concepts. Epidemiology aids in the understanding of the cause of disease by knowing its distribution, determinants in terms of person, place, and time, and natural history. So we're always going to be focusing on the person, those individual characteristics that led to disease, the place where the exposure occurred, and time when the exposure occurred. So person, place, and time. You have to remember that. All right, so the 3 Ds of epidemiology. So we've got the distribution, the determinants, and the deterrents. So with the distribution, we want to understand how disease is distributed. The assumption is that disease is not a random event and occurs at different rates in different populations. And this is, where you're going to be looking at. They all tie in together. But the distribution is one of those key areas. Next is the determinants. So what factors cause disease to increase or decrease? Looking at these factors can give us clues as to the cause of a disease. These factors can be called risk factors or risk regulators. And then deterrence. Finally, we want to understand either factors that can prevent disease, reduce disease, or cure disease. So again, those are the 3 Ds of epidemiology. Now, some key concepts continued. Understanding the elements involved in the transmission of infectious agents enables IPs to develop strategies that target specific areas in the process. Selecting the appropriate study design is very important. There's an entire chapter on study design where we'll go over cohort studies, case control studies, all of the fun stuff. But selecting the appropriate study design is extremely important in what you're going to investigate. Correct presentation of data to demonstrate outcomes and relationships in a manner that will likely encourage collaboration and support among stakeholders. And this is a big thing for IPs. So we have to ensure that when we're presenting data to people in leadership, whether it's the C-suite or your clinical outcomes people, patient safety, high reliability, all of that good stuff, you have to make sure that you're presenting data in a way that it's digestible, right? It needs to be digestible, it needs to be easily understood, and it needs to be impactful in order for it to really lead to some changes, whether it's in practice or in guidelines. You need to make sure that you're doing a good job at displaying your data. So how the ghost map helped end a killer disease. This is a really great TED talk, and it's all about the cholera outbreak. So if I'm sure we all know this story, so I'm not gonna go into it, but it is a great 10-minute TED talk that talks about the importance of epidemiology. It talks about the importance of collaboration. So sometimes you have people who are very intelligent and creative, but may struggle with the relationship aspects of how to get people involved or how to get people to listen to them. Sometimes you have people who are so extremely intelligent that they struggle to really be able to explain the information in a way that's digestible, for people who may not have all of the understanding or expertise that that person has. So it's always important to have a good balance. All right, background continued. So the infectious disease process is a set of complex interrelationships of agent, host, and environment that has been studied by epidemiologists for more than a century. And this epidemiologic triangle model of disease causation is very important. They will find different ways to ask you about this triangle. So you have to make sure you remember you've got your host, your environment, and your agent. It's an important piece of knowledge that you need to have for your tests. Epidemiology as a discipline incorporates the use of statistics to determine associations and test hypotheses, which is why I'm really excited for Danielle to do a deeper dive into statistics and the statistics that you'll need to know for this test. Unlike clinical medicine, epidemiology is population-based and is useful for describing health-related phenomena in groups of people. Again, we're always focusing on and you can look at it as, as if you're an IP working in an acute care hospital or an ambulatory center or an LTAC, that is the population that you're working to help. That's where all of the process improvement projects are happening so that it can lead to better outcomes for your patients. Depending on what types of issues you may be experiencing in your facility. So agent is going to be what? Our environment is going to be where? And our host is going to be who? Okay, so association. Association occurs if, as one variable changes, there is a concomitant or resultant change in the quantity or quality of another variable. That seems a little bit confusing, but it makes a lot more sense when you start getting into some of the different aspects of association that you're working with. So when a statistical association between a factor and a disease has been demonstrated, it may be of three types. So you have artifactual. Artifactual associations can be caused by errors in study design or analysis leading to the introduction of systematic error or bias. This can be spurious. Spurious, so not being what it purports to be, false or fake. Indirect or non-causal is another one. So they may result from the mixing of effects between the exposure, the disease, and a third factor, or a confounding variable that may be associated with the exposure and independently affect the outcome of interest. And then you have causal. And with causal, it's a much deeper dive that you need to consider. So again, we went over artificial or spurious. You're looking at bias, error in analysis, failure to control those confounding variables, indirect or non-causal, and then causal. So causal occurs when evidence indicates that one factor is clearly shown to increase increase the probability of the occurrence of a disease. You can't confuse causal associations with causality. All right, they cannot be confused. So you're increasing the probability of the occurrence of a disease, and causality is a whole nother ball game. So for the exam, and for my people who have taken epi courses, you have already heard about Bradford Hill's criteria for causation. Um, it is beautiful, right? So you've got your strength of association. These are the different types of criteria that you can look at to determine whether there's, an increased probability of a connection with a disease, an outcome. There's all of these different types of criteria that you look towards. Am I meeting? Is this a causal relationship? These are the types of criteria that you're looking at. So strength of association is going to be the stronger the relation between a risk factor and the effect or outcome, the less likely it is that the relation is due to a third or extraneous factor. Next is consistency. You've got multiple studies in a range of settings that are reporting similar results. And this is extremely important, right? I can give you an example recently of just consistency in general. When you're trying to advocate to bring a new product on your facility or your campus, for example, antimicrobial impregnated picks, you have to make sure that when you are putting all of that data together and you're looking at and you're looking to present this to an entire vascular access committee, that you're looking at what multiple papers are saying, right? You're not just going to bring one paper to the committee and say, all right, listen, these people, they had great outcomes, and can you hand over 30 grand for us to move forward with this? Because let me tell you, this is an excellent paper, and I think that we can do this. I think that we all know that that probably would not go over very well with some of the leadership in our facilities. But it is very important to make sure that you have consistency. You have to have those multiple studies in a range of settings that are reporting those similar results to really push you in the right direction. Specificity, ideally the effect only has one cause. Temporality, the purported cause should be present before the effect occurs, so it has to happen before. Biological gradient, a dose response relation between the risk factor and the effect. Biological plausibility, there should be a rational and theoretical basis explaining how or why the risk factor led to the effect. Coherence, which is the association, should not conflict with known facts. Experimental evidence, is there any supportive research based on experiment? If preventative action is taken, does the effect dissipate? And then analogy. A previously accepted phenomenon in one area can be applied to another. So those are Bradford Hill criteria for causation. The way you're going to be asked about it on the test is they can probably give you, you'll see a question here in a second, but they'll probably give you either different sets of examples and you'll have to determine what criteria it is, or they could say which of the following is an example of consistency. Which of the following is an example of strength of association or temporality? And then they'll give you different options and you have to essentially pick which one it is. But it's important to know this. If you have not taken an epi class or if you are not familiar with this, let me tell you something, and I will always tell everyone in my study group this. YouTube has amazing content. There are so many classes online that you can take. There's edX, which includes universities like Harvard, all I don't even know how many. There's so many. There's Coursera, where you can also take additional classes. There is YouTube videos from organizations, schools of medicine, um, universities that will cover so much of this information. So if you feel like I'm not understanding this, let me tell you something. You can either read more about it, listen to lectures about it, or find a way to get that information. Um, the information is available. So here's an example. An example is a challenge to the causal association of smoking and lung cancer. The tobacco industry maintains that the association between smoking and lung cancer is the result of some yet to be defined variable, and that the association with smoking is only a spurious result. The tobacco industry uses the argument that not all people who develop lung cancer are smokers. However, epidemiological research and analyses of many studies have demonstrated that smoking meets Hill's criteria for causality of lung cancer and a number of other diseases. So, gotta love our people who are doing the analysis, the statistics, using SAS, all of those other amazing, fabulous, fantabulous biostatisticians out there in the world, literally just being the baddiest baddies that they can be. So shout out to you guys. You may not be on this call, but just know that we appreciate you wherever you are, and whatever Excel file you're working on or our package or whatever you're doing, just keep on doing it because we need it. We need it badly on this entire planet. So levels of prevention. Now, this is the basics. We go through this in all of our public health courses, even not just public health courses, just in general when it comes to when it comes to health, wellness, all of this stuff. So you've got your different levels of prevention. So primary is going to be when there's no disease. There's no disease, right? So the goal is the complete prevention of a disease before any manifestation of that disease occurs. So that's primary prevention. What are some examples? Wellness programs, immunizations, folic acid, exercise, seatbelts. We're trying to prevent. We're focusing on all of that primary prevention. So, for example, Advent Health has a program where you have to, you have to do um, your biometrics every year. You get points for completing exercise, all of that good stuff. They're trying to help prevent. Next, it's secondary prevention. This is where illness is starting, but you may be asymptomatic disease. So early diagnosis and treatment. You want to prevent further deterioration by intervention as early in the disease course as possible. So screenings, skin testings, like PPDs, mammograms, right? Pap smears, all of this stuff. You're really trying to make sure that you're identifying things as early as possible. After you have that clinical diagnosis, then you're moving into tertiary prevention. So what can we do to reduce our complications? Rehabilitation, organ transplantation, medication management. So are you on the right regimen if you're a diabetic? Do you need to see an endocrinologist? Are your levels not where they need to be? What about exercise? What are the kinds of things that we can do to make sure that your disease is not advancing? And so these are going to be our 3 levels of prevention. Okay, so let's do some matching. So you've got all of your definitions up at the top. Sorry, not the definitions, the words that you got to pick up at the top. And then we'll start with the first one. So the number of existent cases of a given disease at a given time. Again, that's the number of existent cases of a given disease at a given time. Go ahead and put your answers in the chat. I'm getting, ooh, I've got prevalence, incidence, endemic. Incidence again. Okay, getting lots of different choices here. So the number of existent cases of a given disease at any given time, that's going to be prevalence. So for all of my peeps that said prevalence, 10 out of 10. All right, next one. An excess over the expected incidence of disease within a given geographical area during a specified time period. Again, that's an excess over the expected incidence of disease within a given geographical area during a specified time period. Okay, for this one, the majority is either between epidemic or endemic. Interesting. Epidemic, very good. An epidemic spread over a wide geographical area across countries or continents. Yeah, you should know this one. A pandemic, a panoramic, a panini. You call it what you want. It's a pandemic. Okay, so the usual incidence of a given disease within a geographical area during a specified time period. The usual incidence of a given disease within a geographical area during a specified time period. All right, yes, endemic. Very good, guys. Next one is a sudden increase in occurrences of a disease in a particular time and place. Excellent. Outbreak is correct. And then the very last one is the number of new cases of a given disease in a given time period. That's going to be our incidence. You have to be very careful. So I saw a lot of you putting incidence for the first one, the number of existent cases. When with incidence, we're focusing on the number of new cases. So incidence and prevalence, I know can sometimes be confusing, um, but we gotta get that down. We gotta get that down for reals, for reals. Okay, so next, our next couple of words are going to be reservoir, fomite, herd immunity, risk, and risk factor. So the first one, the probability or likelihood of an event occurring. The probability or likelihood of an event occurring. Risk, very good. A place in which an infectious agent can survive, but may or may not multiply. It may or may not multiply, guys. It may or may not. And it can survive. Reservoir, very good. Very good. Some of you put fomite, but we'll get to why that was not fomite. So the next one is a characteristic behavior or experience that increases the probability of developing a negative health status. Right, yes, yes. Very good. Risk factor is correct. All right, this one is an inanimate object on which organisms may exist for some period of time, right? Very good. So yes, that's going to be our fomite. So with our reservoir, that infectious agent may or may not multiply, right? So that means that depending on what that reservoir is, it could be a living thing. It could be a mosquito. It could be a camel, a bat. It could be lots of different things. But with an inanimate object, that's going to be your fomite. That's going to be that people are coming out with the animals. I'm getting armadillos. Okay, let's go, armadillo gang. They are so cute. Armadillos are very cute. It's a shame. It's a shame you can't just hold them. But anyway, that's for another day. So yeah, with your fomites, you're focusing on those inanimate objects. Okay. Um, The next one is the resistance of a group to invasion and to the spread of an infectious agent based on the immunity of a high proportion of individual members of the group. And that's going to be herd immunity, which we've heard lots about over the past couple of years. Okay, so healthcare associated infections and community acquired infection. So healthcare associated infection is not present at the time of admission to the healthcare facility, but are temporally associated with an admission to or a procedure performed in a healthcare facility. So with our HAIs, we've got our big buckets, right? We've got our CLABSIs, our CAUTIs, our VAEs, our SSIs. Those are some of our biggest healthcare associated infections. Obviously our lab IDs. And then an infection that's present on admission can also be healthcare associated if it's related to a recent hospitalization. Like for example, I can think of community onset healthcare facility associated, like C. diff, where if you've been exposed to a healthcare facility within the past couple of days, I can't remember if it's 28 days, but it gains that designation. And then community acquired is an infection present on admission with no association to a recent hospitalization. All right, question 1. A causal association is a false association that can be due to chance or bias in study methods. 2, mixing of effects among exposures, disease, and a third factor that is associated with the exposure and independently affects the outcome. 3, when evidence indicates that one factor is clearly shown to increase the probability of occurrence of a disease. And 4, determined through a set of criteria including strength of identification, consistency, and biological plausibility. So question 1 is a causal association, and you can go ahead and put what you think the answer is. Wow, strong group today. Very good. Like, all of y'all put C. There's not a single other letter in here. Everybody put C. Very good. Yes. When evidence indicates that one factor is clearly shown to increase the probability of occurrence of a disease. And again, we're talking about Bradford Hill's criteria, where we've got that set of criteria that we're looking for to ensure that we've got that causal relationship. All right, question number 2. Which of the following is an example of the criterion of strength of association from Hill's criteria for causation? So, A, in a study of the association between antibiotic exposure and development of C. difficile infection, the odds ratio was 2 to 3. B, in a study of the association between antibiotic exposure and development of C. diff infection, the author's conclusions are consistent with those of 3 other studies. C, in a study of the association between antibiotic exposure and development of C. diff infection, antibiotic therapy began on an average of 3 weeks before the C. diff infection. Or D, in a study of the association between antibiotic exposure and development of C. diff infection, prolonged antibiotic therapy was a greater risk factor for C. diff infection. Okay, I've got a lot of, let me tell you what I got. Okay, I have a lot of A's, some D's, some C's. Okay, so where's my little pen thing? How do I do a pen? You know what? Let me not do the, well, should I? Let me just do the drawing tools. But I feel like I always struggle. Okay, so conclusions that are consistent with those of 3 other studies. Which Bradford Hill criteria am I working with there? There's there's a keyword. There's a keyword right here. We're dealing with consistency, right? That's gonna be what we're working with that with that option B. Antibiotic therapy began an average of 3 weeks before C. difficile infection. So with antibiotic therapy beginning an average of 3 weeks before, which one are we working with there? Let me see. Temporality, very good. And then D. Wait, sorry, 3 weeks before. And then D. Prolonged antibiotic therapy was a greater risk factor for C. difficile infection. Which one are we dealing with there? Why do I stop using this pen? Erase all drawings. Okay, there we go. All right, let's see what you guys are putting. Okay, I got dose response. I got dose response. Any other options? Why are you not working? Oh my goodness. There we go. Okay, I got it back. Ooh, you know what? That's it. I can't use the pen. It confuses me and then I can't, it's like, it's just, it's too much. It's too much. I have limits. Okay. I forgot what I was even doing. Okay, so the correct answer is A. In a study of the association between antibiotic exposure and development of C. diff infection, the odds ratio was 2 to 3. So yes, that's going to be our strength of association. That's going to be our option. Okay, next one. An acute care facility experiences an outbreak of Serratia marcescens bloodstream infections. After the outbreak is under control and no new cases are being reported, the IP wants to find the source of the outbreak. The most appropriate epidemiology study design to use is A, retrospective cohort study, B, prospective cohort study, C, case control study, D, cross-sectional study. Let me see what my options are, what kind of options are coming through. Okay, lots of question marks. People are like, A? I don't know. C, maybe? Okay. So it's going to be a case control study. Case control studies group people by disease status and then investigate past exposures with the objective of identifying exposures that are more common to cases than to controls. This is an appropriate study design for this example because there are existing cases and the IP is trying to identify the exposures that are associated with the bloodstream infections. Let me tell you, bold, okay? That is you wanting to find the source of the outbreak. That is number one. It's a lot of work. It's a lot of work. Um, but number two, um, the there's only been one really where we were able to figure out what was causing the Burkholderia infections, and it was because of a recall that got sent out. I'm sure you guys remember. Um, but yeah, those are far and few in between. Those are some of the most exciting lectures to see when you go to conferences where they can tell you everything they did. Oh, I can't wait to be back in a conference. It's going to be so much fun. Okay, the epidemiologic triangle model for disease causation does not include A, agent, B, host, C, time, or D, environment. If you get a question like this on the test, you're just going to hit the right answer. You're going to keep it moving. Don't even. Just if you either know it or you don't know it. Okay. And this is time. Remember I told you this little triangle was going to be important? Your agent, host, and environment. All right, question 5. Which of the following are considered primary prevention measures? 1, barrier precautions, 2, immunization of healthcare personnel, 3, cleaning and disinfection, or 4, sterilization. So which of the following are considered primary prevention measures? Very good for all those of you who put D. Primary prevention strategies aim to reduce the risk of disease transmission. All right, Chapter 11, surveillance. This is just one question because we're going to get into Chapter 12. So question 1, you are the IP at a small rural hospital and have been monitoring all surgical cases for infection. You want to know if your SSI rates are acceptable. What would be your best action? A, look for specific high volume surgeries and compare to the published literature for each type. B, network with other local hospitals of the same size and compare your rates using a t-test. C, calculate a total SSI rate and compare to previous rates for your facility. Or D, review national NHSN rates and compare individual surgery types using a z-test. So which one are you going to do? Very good. To all my people who are saying D, review national NHSN rates and compare individual surgery types using a z-test. So let's go into the why. The goals of NHSN are to provide an estimate of the magnitude of HAIs, identify and provide data trends, assist inter and intra-hospital comparisons with risk-adjusted HAI data, help member facilities develop surveillance and analysis methods, and encourage prompt intervention to improve outcomes. NHSN is the gold standard for sharing HAI data, benchmarking for healthcare facilities, and providing validated parameters for risk models. The z-test is a common statistical test used in infection prevention with data that is normally distributed and when the sample size is 30. Okay, so Chapter 12, Outbreak Investigations. Okay. Okay, HAI outbreak investigations, so healthcare associated infection outbreak investigations. Yeah, this is my jam. Okay. A proper an outbreak investigation is is just like nothing else that there is out there. It's very hard work. It takes a lot of brain power. It takes a lot of coordination, a lot of teamwork. But having the opportunity to have worked on, I feel like the first outbreak I worked as an HI epidemiologist is the reason of where I am now in life, just in general. So it's yeah, it's just outbreak investigations are very exciting, and it's amazing work that our public health experts and our IPs and everyone else is doing. So cooperation between healthcare epidemiologists, infection preventionists, and public health experts is important in effectively managing outbreak response in healthcare settings. And we'll dive a bit more into why that is the truth. Outbreaks in healthcare are often multifactorial. So you're looking at lapses in infection prevention or clinical practices, colonization or infection of healthcare personnel, defects in or contamination of a product or device. Like I said, that's the most recent one that I've been involved with, was the recall of um, the oral chlorhexidine, with, was it was it Sunquest Laboratories? I can't remember. That was contaminated with Burkholderia. So yes, contamination, and there's so many other examples just besides that one. Um, Seriously, it's amazing. The goals of an outbreak investigation are to identify contributing factors to control the outbreak, and what? No, 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 don't do that. Okay. The goals of an outbreak investigation are to identify contributing factors to control the outbreak and prevent similar outbreaks in the future. So, HAI outbreak identification. Outbreaks in healthcare should be suspected when healthcare associated infections or adverse events occur above the baseline rate or when an unusual microbe or adverse event is recognized. This is an extremely important bullet point. When you have the suspicion, hey, I think something funny is going on in my ICU. I have had more Acinetobacter than I'm used to seeing, or I'm seeing more Serratia than I'm used to seeing, or Pseudomonas, or whatever it is that you may be seeing. The first thing that you need to ask yourself is, what is my baseline? What does my baseline look like? Do I, on average, get one case of Serratia per month? Do I get two? Do I get three? Where is the Serratia being identified? Is it primarily in respiratory specimens? Is it in the blood? You need to know what your baseline rate is, because that's how you're going to be able to tell your leadership, hey, there's something that's wrong. Something's not right. Because on average, we have X, Y, and Z. And now I've had X, Y, and Z. So for example, for the Burkholderia investigation, I saw a case of Burkholderia in the ICU, and I was just like, wait a minute, what are you doing here? Okay, girlie, you do not belong here. Not in here. Not in my ICU. I've never seen you before. Okay, where did you come from? You're not from these parts of town. You are not from this neighborhood. So immediately, what I did was went to the lab and said, hey, can you let me know how many cases of Burkholderia we've had in this facility? Bada bing, bada boom. Actually, you haven't had one in like forever and a bajillion years. Oh, interesting. Well, when the second one came up, let me tell you, it was like Beyonce's Ring the Alarm, her music video, like ring the alarm, something's going on. This isn't right. So you need to know this. When you have a suspicion, you gotta focus on your baseline information, because that's how you're going to present it to your leadership. The Pseudomonas is out of control. Okay, but if you always have three or four, and you had five this month, that may not be enough to really warrant alarm bells to go off. A single case of an unusual disease may constitute an outbreak. Extremely important as we head into even more troubling times than we are in already with antimicrobial resistance. We've got Candida auris, we've got VIM, NDM, IMP, OXA48, just all over town, right? And so if you have an unusual disease, that can in itself constitute an outbreak. It doesn't always have to be multiple cases. It really depends on your region, on your area, on what's going on in your community. This is specifically for Florida, so we won't go into it too much, but just know that you've got reportable diseases and conditions that as an infection preventionist you need to be aware of. So if you're in Florida, you're looking at your reportable diseases and conditions in Florida. If you're in Tennessee, you've got a different list. If you're out in California, you've got your list. So outbreak reporting, this is what it says for Florida. Outbreaks of any disease, any case, cluster of cases, or exposure to an infectious or non-infectious disease, condition or agent found in the general community or any defined setting, hospital, school, other institution, not listed that is of urgent public health significance, report immediately 24/7 by phone upon initial suspicion or laboratory test order. So it doesn't always have to be multiple cases. Outbreak investigations can be divided into two major sections, the initial investigation and the follow-up investigation. So what are going to be some of your primary components of the initial investigation? Confirming the presence of an outbreak. That's where you're starting with your baseline data. That's where you're starting to see, oh, well, how many cases of X, Y, and Z have been reported in the state, in the county. Alerting key partners about the investigation. You have to have your public health people on speed dial. You have to know how to get a hold of them, their on call numbers. Collaboration with the health department is extremely important. Alvina Chu, always taught me you have to perform a literature review. So I would come to her with a concern or with an issue. Well, what does the literature say? I remember a colleague from Miami called me and they were like, "Hey, you know what? We're experiencing like a really high increase in Mycobacterium abscessus cases associated with BBLs down here in Miami. Like, can you like let's walk through this? Like, let's talk about it." And I called Alvina. I'm like, "Hey, this stuff is going on," and she was like, "Oh, well, what does the literature say?" So immediately I was like, "Oh, okay, I'll talk to you about this later," because I knew I hadn't done my homework. I hadn't performed my literature review. I hadn't looked at all of the things that I needed to look at what could potentially be leading to this increase in cases. You have to have access to published work, whether it's through your hospital or I don't know, if you're in school through the university you're going to, but you have to have access to that as an infection preventionist. It's so important because the second that you start to see an increase in cases or something that's abnormal in your facility, you need to have the ability to say, okay, let me think of a surgery. Knee, okay, a K-Pro, right? I've noticed an increase in my knee, my K-Pro SSIs. You should be able to pull up literature. This is the organism that I'm seeing. These are potential causes. This is what the research tells me, and you have to let that guide you as well. Establishing a preliminary case definition, developing a methodology for case finding, preparing an initial line list and epidemic curve. And if you don't know how to do an epi curve, there's lots of tutorials online. CDC has great information on how to put your epi curve together. Observing and reviewing potentially implicated patient care activities, considering whether environmental sampling should be performed. Ooh, and honey, that is expensive. So just be prepared if that's where you end up going to, because that is very pricey. And implementing initial control measures. Conducting an outbreak investigation continued. So you've got your primary components of the follow-up investigation, which are refining the case definition after you've started to gather all of your data, continuing case finding and surveillance, reviewing regulatory control measures, and considering whether an analytic study should be performed. Important to note, many steps might occur simultaneously and be repeated multiple times in the course of the investigation, because if there's one thing about an outbreak is that, let me tell you, it is never just like point A to point B. You gotta go through the whole alphabet to get to where you're trying to get to. And so one of your team members may be working on the lit review while another team member is working on the epi curve, while another team member is doing some data abstraction on the different types of uh, exposures that the patients have in common. So just know that it can be it's the most chaotic fun you'll ever have. That's what I'll tell you. It is the most chaotic fun that you will ever have. Um, um, what was the name of the outbreak for BBLs again? It was Mycobacterium abscessus. Mycobacterium abscessus. Okay. A document that you need to be familiar with, whether you're an infection preventionist or you work in public health, it's the Interim Guidance for a Public Health Response to Contain Novel or Targeted Multi-Drug Resistant Organisms. You have to know this document. Do you have to know it backwards, forwards? No, but you need to know that it exists. Okay, you need to know that it exists, and I would recommend, it's not a very long document. I would recommend that you at least read through it once, because it's really going to give you lots of key information that you'll need to know about managing an outbreak, depending on the type of tier that you're working with. So HI outbreak response, some of our goals of the containment are going to be to identify our affected patients, ensuring appropriate control measures are promptly implemented to contain the further spread, determining if transmission and dissemination is occurring, and characterizing the organisms or mechanism in order to guide further response actions, patient management, and future responses. So these are some of the key definitions. You've got your healthcare facility. So for this guidance, the term healthcare facility refers to all acute care hospitals and post-acute care facilities that care for patients or residents who remain overnight and require medical care, nursing care, or rehabilitation services. Okay, and this generally excludes our ALFs. Colonization screenings. Oh, let me tell you, you have to know this document, because when the health department is calling you and telling you, hey, we need to do a point prevalence survey because we've identified a case of Candida auris in your facility, your leadership is going to be looking to you to say, what is a point prevalence survey? What is a colonization screening? What are they saying that we're going to need to do? Do we need to involve legal? Do we need to call the lawyers? What's happening? What does the process look like? You need to be familiar with the document. So for colonization screening, when an emerging MDRO is identified, colonization screening is recommended by CDC as an essential component of the public health response. Colonization screening identifies unrecognized carriers so that infection control measures can be targeted to prevent the spread of antimicrobial resistance. And that colonization screening may vary. It could very well be a rectal swab, or it could be an axillary groin swab if it's Candida auris. It really, yeah, it's going to depend on what you're working with. And then you've got your response tiers. So I won't go into that there, but you've got your tier 1, your tier 2, and your tier 3. And this is essentially the buckets where different types of organisms are going to fall depending on your specific geographical location, what's going on in your community, what's going on in your county, in your hospital, in just your area in general. So your organism response, tier 1. Tier 1 is our highest response, and it contains resistance mechanisms novel to the United States. We may be seeing them on other parts of the world, but not here in the US. Um, pan-resistant organisms. It needs more extensive evaluation to better define risk for transmission. And an example would be like pan-resistant OXA23, Acinetobacter baumannii. All right, tier 2. Primarily found in healthcare settings, but not believed to be found regularly in the region. Information is available about how transmission occurs and groups primarily at risk. Examples would be like our OXA48 type producing CRE, been producing Pseudomonas aeruginosa. Um, I know we need to look at my NHSN mapping, Taylor. I know, I'm going to call you, don't worry. um, gotta love my people. Um, but yes, and then tier 3, already established in the United States and have been identified in the region before. They are not endemic. Information is available about transmission. And then you've got carbapenem-resistant Enterobacteriaceae producing Klebsiella pneumoniae. Carbapenemase, just lots of different options here. Okay, so I'm going to dive into strategy specific to tier 2, because tier 2 is the outbreak that I'm going to be talking about. So after identification, prompt notification to the patient's primary giver, patient care personnel, other healthcare staff per facility policies, procedures, and local and state health departments as required. There's going to be implementation of appropriate infection control measures, informing the patient and the family, screening cultures of index patient after 1 month has passed since initial culture was collected, and then conducting a healthcare investigation, looking at the exposures over the preceding month. Conducting a contact investigation, so cultures of epidemiologically linked patients like roommates, if you're in a facility where you're sharing. Screening additional patients is dependent upon whether the index patient was on contact precautions or not during their entire stay. This is a very, very important piece because when the health department reaches out to you, they're going to specifically ask you, at what date and time did this patient get placed on the appropriate isolation precautions? For our MDROs, it's going to be contact, and you need to make sure that you have that available, because if they were not on contact from the time of admission, then you're in a situation there. Environmental cultures in these situations are generally not recommended unless transmission is identified or suspected. Implement a system to ensure adherence to infection control measures. So that's education, ensuring people have adequate supplies, monitoring adherence to infection control practices, and communication to transferring facilities or discharging facilities. Okay, so for the end of this, we're going to talk about the outbreak that got me started in infection prevention, the outbreak that just absolutely made me fall in love with everything that has to do with infection prevention. So this is an outbreak of Verona integron-encoded metallo-beta-lactamase producing Pseudomonas aeruginosa that happened in Orange County. This outbreak, I worked with one of my best friends, Danielle Rankin. As I've told you, she's doing her PhD at Vandy, and it really just, it's the reason why Pseudomonas aeruginosa is um, my favorite bacteria, because of this outbreak. So on July 5th of 2017, we were identified of one case of colonization with Verona integron encoded metallo-beta lactamase producing Pseudomonas aeruginosa, VIM. We're going to refer to it as VIM from now on, in a long-term acute care hospital in Orange County, Florida. And this was the first time that we had VIM reported in Florida at the time. And we reached out to that facility, made sure the patient was placed on contact precautions. We requested full medical records for the patient, transfer admission sheets, proxy information, reviewed those medical records, and looked at healthcare exposures prior to and after the positive laboratory results were identified. So things moved relatively quickly. So on 5th, we get notified by the Bureau of Public Health Laboratories, hey, you've got VIM. We have VIM in Florida. On the 6th, we are scheduling an in-person meeting with the facility infection preventionist and CEO of that facility to discuss the outbreak response. So you can imagine you're walking in and basically telling them like, hey, this has never been seen in the state before, and we're going to need to conduct an investigation. On the 7th, we provided the Florida HI Prevention Program updates on the outbreak investigation and obtained guidance on our response efforts. And then by the 10th, so 5 days after we were initially notified of this, we're already having a joint call with the Florida HI program, CDC, and obviously our local health department. That's where I got my start in epidemiology, was at the Department of Health in Orange County, under Alvina Chu's leadership, and she's just amazing. She came from Maryland, just wonderful, wonderful mentor, and just exceptional person. So we conduct a contact investigation. So here's the thing that I want you to understand. This document, right, that you need to be familiar with, it has rules, not rules, it has guidelines. It gives you steps. It lets you know this is how you should approach things. This is the direction that you want to go in, which is why it's so important to be familiar with it, so that when you're involved in an investigation, you know how to guide your facility and your leadership through it. In response, the patient was placed on contact precautions, and a facility-wide point prevalence survey was conducted on July 13th. So what that essentially meant was that for that whole entire long-term acute care hospital, we did rectal swabs for every single patient who consented. And what that involved was working with that LTAC's legal team, ensuring that we had an appropriate consent sheet, education, answering questions for patients. Why is this being done? What is the issue? And it was facility wide. It wasn't, just like the person next to them, or, to the right or to the left or across the hall. It was the whole facility. We coordinated the collection, the packaging, the shipping of all of the materials, everything, and implemented enhanced prospective laboratory surveillance at the facility. So again, you've got your summary of your response. We're always working on this tier 2. So screening of healthcare roommates, always. Broader screening of healthcare contacts, sometimes. Prospective lab surveillance, always. Retrospective lab surveillance, always. Household contact screening, rare. Environmental sampling, rare. And healthcare personnel screening, rare. So What were our results? On July 14th, the Tennessee Public Health Laboratory provided us with preliminary lab results, which indicated 3 VIM cases and 5 KPC cases. We ensured that those patients were placed on contact precautions, second point prevalence surveys were scheduled, and additional medical records were requested. So this is the investigation timeline. I think the most important thing here is, do you remember earlier on in the presentation when I said it doesn't, for there to be an outbreak, it doesn't mean that you need multiple cases, right? So we mounted an entire response to one case of VIM and identified an additional 12, a total of 13 VIM cases in Florida. We went from not having it or having it identified in the state to 13 cases, right? So it really shows the importance of surveillance and response when we find these organisms to try to prevent them from really getting out into the community. This investigation was so consuming and so rewarding at the same time. So we did in August we did our first infection control assessment on and response, our first ICAR. That was my very first ICAR. It included hand hygiene, personal protective equipment audits, and we started that admission screening, right? So any patient that was coming into that facility had to have a rectal swab upon admission and a rectal swab upon discharge, because we were trying to figure out, are they coming in with this, or are they acquiring while they're in this environment? Continued to do point prevalence surveys, environmental observations. We did device reprocessing observations, looking at how they clean their scopes, looking at everything, how they clean their rooms, hand hygiene, personal protective equipment adherence, all of this. We were looking at all of this. And then in November, one of the most just probably rewarding couple days of my life occurred when we had a site visit. It was a joint site visit between the Department of Health and CDC. And, at that point, we had continued to see cases in the facility, and they were being attributed to the facility, right? So these people were not coming in with the VIM; they were acquiring while at the LTAC. And so CDC came down and they sent this just amazing team of just phenomenal women that provided so much guidance and knowledge on how to respond to an outbreak. And that was when we did environmental sampling. And that's the story I always tell you guys about how I wanted to be the sampling fairy and sample everything. And I was told, you never do that. You always let your data guide you. Your data has to guide you. It has to be that compass that's pointing you towards where those exposures happened. What are the likely things that could be leading to this? And then it continued on. And as you can see, the cases started to taper off, and we eventually closed the outbreak. But it was a very long time, and it was a lot of point prevalence surveys that we did. These are some of the results of the ICAR results as time passed by. So you can see how we went from that 61% hand hygiene adherence rate to, our highest being 90%, and then just overall improving significantly when looking at those hand hygiene results, as well as our glove adherence, gown adherence. Still not really where it needed to be, but it did show some improvement over time. And so very quickly, let's do a concept check. So the director of the operating room requests that the OR surfaces be routinely environmentally cultured. The IP's best response should be a schedule for routine culturing of the OR should be arranged so that each room is cultured at a set interval. B, routine culturing of the OR should be done in the absence of any epidemiologic investigations in that area. C, routine culturing should not be done because it is too expensive. Or D, routine culturing should not be considered unless an epidemiologic investigation is being conducted. We're going to do this one really quick. Oh, I already have so many answers. Yes, it's D. You have to remember this when it comes to environmental culturing. You can't be loose, okay? You can't be the environmental sampling fairy. Cut it out. You have to let your data guide you. Again, okay, because it's costly and you need to make sure your data is guiding you. So what were our results? We ended up finding, this is from our environmental sampling results. We ended up finding VIM producing Pseudomonas aeruginosa in the patient sink area. KPC, again, in our patient sink area, and KPC, Enterobacter cloacae, in the patient sink area. This is one of the biggest opportunities that we have as infection preventionists, and that is improving the sink etiquette in our healthcare facilities. It is a daily fight that we need to continue doing because there are organisms that are partying in the pipes. They are partying, they are having a great time, just having a wonderful, absolutely fantabulous time. And we need to prevent them from partying in our patients. Okay, we have to do a better job of educating our frontline healthcare teams about the risks of splash zones, waterborne pathogens. Absolutely. More pictures here of the things that we found in sink drains, KPC. Again, Vim, Pseudomonas producing aeruginosa, and in the ICU at this LTAC, they had Swivet toilets that you would pull out, and they were right above, so they were like right down here, right down here. So you would pull them out, flush them, and then guess where all of those particles would go? Right up here, where you've got your peg tube flushes, where you've got your meds, where you've got the workspace for the nurse where they're putting all of their supplies. Oh, and by the way, this is oral chlorhexidine right here, a med, right? So the VIM producing Pseudomonas susceptibility pattern for our organism at that time, it was susceptible only to amikacin and colistin. So definitely, very, very, very resistant pathogen. And these are some pictures of Danielle and I. So when they, came to have us collect aerators and collect water samples, we collected water samples of the water that's coming in from the county, the water in the facility. We talked to them about their water management program. This is Danielle here, and then that's me back in the day when I was an HI epidemiologist. And this is what started my love for IP and infection prevention, and the reason why I continue to grow and learn, and the reason why I continue to do these meetings every Friday. It's because it's it's just I love this work so much. I love the work that we do so much. It's so important. Sorry. We're behind the scenes and we work so hard to protect people and to protect patients. So we have to continue to love the work that we do, share it with people, continue to bring young, lovely, intelligent people into this field who are just starting out, who are learning about epidemiology, bringing all sorts of different disciplines into this world because it is just amazing, and we have to keep doing it. So um, yeah, I'm gonna finish it there. I had some questions, but I'm way over time, so we'll go ahead and end it here. So if you have any questions, please let me know now. I'm gonna stop the recording, so just in case you guys have questions. Sorry, I got a little emotional there, but I just infection prevention is just where it's the best, and public health, both. Okay, how do I stop this recording? I don't even know. Oh, here it is, record, stop. Okay.